What I'd like to speak with you about today is a proposal for a coordinate mapping system for HS. And just from some of the comments that have been made earlier this morning, I think that this may potentially be quite useful in terms of not only identifying how we can measure and provide a quantitative measurement as to the distribution of lesions in HS, but also how to measure the changes over time and measure changes with other interventions, whether medical, surgical or other. So I don't have any conflicts of interest to declare. And just in terms of the objectives here, in terms of understanding the utility of lesion mapping, the applications of a proposed system, and where future avenues of research may be able to be applied with this. So we know of recent years that the natural history of HS lesions, we're starting to get a bit more of an understanding about them, but our current investigative mode in terms of investigating lesional and perilesional sites for our understanding of the pathophysiology is a little bit rough and ready. So at the moment we have a typical axilla affected by HS, and let's see if this clicker is going to work here. So at the moment we would say take a lesional site and then a perilesional site and then measure markers, say certain cytokines, and say these are different and these are statistically significant, and then go on from there. But it doesn't really tell us what's the most interesting aspect and what's the most important aspect in terms of HS. Is it distributed, purely in the axillary vault with a slow progression outwards from there, or is it mostly based in certain follicular units, as would be involved if we think it's purely based on something happening, not just on a general occlusion hypothesis, or are there also subclinical lesions which have increased rates of certain products which may be contributing to the pathophysiology of the disease? Also, there are relevance in terms of when we measure areas in the microbiome, whether there are certain increases in concentrations of certain products, purely in the deep areas of the axillary fold, whether they're scattered around, and all of these different distributions and different modalities can give exactly the same results we're seeing with our current investigative modalities in purely lesional and perilesional areas. But it's really these deeper findings which would give us more of an insight into exactly what occurs to really clear up the difference between, is this purely to do with follicular occlusion? Is the follicular occlusion a confounding factor and it's really more of an inflammatory or an immune-mediated disorder? And so this is where, somewhere like a mapping would come in very, very handy in the future. So at the moment, if we're going to move forward in terms of the pathophysiology of HS, lesional and perilesional is a bit overly simplistic. So what our group in Sydney has decided to propose is that we wanted to develop a mapping system for HS, to be able to sit down, to be able to have objective criteria to say, these numbers represent a certain group of lesions within a body site of HS. We could then monitor these over time. We could use these to map where biopsies are taken, and then down the track with a correlation of hundreds and hundreds of data points, use those data to hopefully find some interesting and insightful measurement properties in terms of what's happening in our patients with HS. We also wanted this to be reproducible and reliable, and hopefully the long-term aim is to integrate this into a computerized mapping data set in order to make it easier to implement further on down the track, and also to enable the data to be easily manipulated. So there are a number of steps in which we wanted to investigate this, and also there are a number of ways in which it can be utilised in the future, as I briefly touched on in the previous few slides. So in terms of the stages that we went through with this, we wanted to identify stable, accessible anatomical surface landmarks, and of course, with a breadth of patients, those who are normally quite slim and of normal BMIs, ranging to very morbidly obese patients. Usually bony landmarks are going to be the most accurate in order to identify. To identify an origin point, to have a baseline to measure whereabouts the lesions in HS are coming from in different anatomical sites as well, measurement modalities, and then in order to ensure that these are valid and reliable ways of measuring, to ensure that across all physicians, wherever they are, what's the error rate, what's the confidence interval that we can say that most people can accurately measure the site of a lesion in HS to, for example, 5 millimeters, 10 millimeters, 15 millimeters. What's the minimum amount of accuracy that we're going to be able to obtain with this system? In terms of the anatomical landmarks, we used our trusty medical student Vitruvius here. and identified a number of bony anatomical landmarks, mostly just through a consensus statement, for example, the sternal notch, the medial epicondyle on the upper limb, and these areas which we did trial in patients and found that the majority of the time we were able to identify most of these bony landmarks on certain individuals with relative ease. Now, these are the proposed anatomical landmarks which we are basically using for both the anterior and posterior surfaces of the patients, and basically just using these simple descriptions as our basis for them validating how accurate this is in terms of identification. In terms of the origin point, we then said, all right, if we draw lines between these mapping bony landmarks and then bisect these lines, we would then be able to identify an area which fits within the axillary vault, within the midline just underneath the xiphisternum here, and also within the axillary folds and the buttocks in order to gather the majority of places where a lot of these HS lesions do occur. So the example would be that if we transposition this picture here and then identify the medial epicondyle and the sternal notch and then bisect this line, the intersection of the dotted line and the straight line there would then represent the origin point, say for the right axilla in this individual. Then in terms of how we're going to measure these individual spots, it's a bit easier to just kind of demonstrate visually. So we would then overlay a centimetre square grid onto the area and basically number them positive and negative, and then identify the certain areas based on what's able to be palpated. These are just for the moment colour-coded based on the different clinical types of things that we can see. For example, nodules in blue, more active draining sinuses in green, and comedones in yellow. And then there are also the palpable but not really clinically evident deeper cystic structures. So we also wanted to, due to the importance of ultrasound emerging in monitoring of HS, see if we could integrate that into a proposed mapping system that we wanted to develop. And the simplest way to do this, although it doesn't really present the very finer details of what is able to be done with ultrasound, we wanted to kind of get the gist of what's happening here. So identified a particular site of the opening into the skin, the orientation of any tunneling or sinuses that are occurring, and then also the inclination deeper down into the skin. So it's kind of extrapolated here in this picture. We were able to identify the opening of the sinus tracts as one point, using the ultrasound and just some simple measurements, the depth of any tracts and the general direction in which the majority of the tracts are sitting there as well. So the hope would be that over time, any particular changes that are occurring there, either in depth, inclination, or length, would be able to be identified by our ultrasound. So the notational system, as we said, our main consideration was integrating this into computer data sets in order to facilitate further statistical analysis down the line. So we wanted to stay with more of a coordinate system in a matrix format, which would then be most easily integrated into future 3D mapping software and also for computerized statistical analysis. So therefore, the notation program that we've kind of noted would be individual lesion sites just via X, Y, and Z coordinates. For larger plaques and ulcerations, we would use a number, between 4 and 6 isolated identification points, which would then define the periphery of a particular site or plaque. And then overlaying that, any open sinuses or tunneling sites would be the particular site of the centre of the ostia, and then again with X delineating the length of the sinus, the particular degree at which it is tunnelling down into, for example 0 degrees being straight up anatomically superior, 180 degrees inferior, and then the inclination corresponding to the depth within the skin there as well. So just as an example here, this would be this right axilla of our subject there, with the delineations in terms of a numerical notation in order to say these numbers would then represent the current activity of the disease at this point in time. So although it looks quite confronting at the present time, the aim would be that by integrating this into any further analyses further down the track, it gives us an objective numerical appreciation of what is changing over time. And at the moment that can be done subjectively, but this kind of presents one of the first objective measurement tools which we hope to then validate in larger cohorts. So at the moment we've done some initial validation studies. which we had 100 patients with 4 HS physicians, currently in my research group, where we had blinded mapping of the anatomical sites of reference to see how accurately and how closely these were mapped to each other, the origin points as well, and then marking out a certain number of sites using pre-written coordinates across the 4 different physicians. So again, just to reiterate, say we had a HS patient, we identified the anatomical sites of reference and identified where they were with baseline photographs, which were then compared between the different physicians, and then also the marking of the origin points, for example, the bisecting of those lines there as well. Then all of these different sites on various different photographs and live patients were then mapped and compared. And then we undertook an analysis of the variance across those 100 patients with 4 different individuals. The most important thing from this busy table is mostly to say that the variance overall between the anatomical points of reference, the measurements of the lesions and the origin points, and also marking points is roughly between 1 or 2 millimeters each. So although the 90% confidence interval is quite wide, what's a more accurate representation is actually the standard error and the standard deviation. So overall, you're having the majority of markings within about 1 to 2 millimeters of each other, which is actually quite impressive considering that the standard is about 400 different sets of data. So another important aspect which can also be used in patient-reported outcome measures as well as these kind of measurement tools is the smallest detectable difference. So statistically speaking, using the standard error of the mean, what will be the smallest difference which is actually going to be able to be detected by this tool? And it was ridiculously small. So 0.3 millimeters, which is nothing in any practical sense that's actually going to be used in a clinical setting, but it gives us the reassurance that the tool is actually valid and able to be used to identify any certain changes. Of course, the difficulty is that the smallest detectable difference, as the variance is quite larger than that, we would then obviously say that the only accurate change that can be detected would be equivalent to the variance. So there's really no benefit in measuring lesions using this standard set more accurately than about 2.5 millimeter intervals. But any change that is beyond 2 millimeters in terms of the size of a lesion, the depth of a tract, is definitely clinically significant. So overall, we understand that there is a need to move beyond our understanding of subjective evaluation of changes in HS. We hope that this coordinate mapping system is a starting point and would be very interested in anyone else's thoughts or interest in collaborating to further validate this and trial this. And at the moment, based on our preliminary evaluations, it's quite valid and reliable and is quite accurate at detecting change over a period of time in patients. So thank you very much. And these are my collaborators, Dr. Vekic, Dr. Woods and Professor Keynes. Thank you.